In the meantime, I would like to introduce our next speaker. This is Dr. Anja Levis. Anja is our fourth fellow. She completed her fellowship this year and is a full member of our small group now. Anja has her particular interest and research on hemodynamic monitoring and targeted treatment of patients on cardiopulmonary bypass following cardiac arrest and resuscitation.
Okay, as Gabor already introduced with the poll, we will talk about how much blood flow is fine with antegrade cerebral perfusion, and I will just go very quickly over our first few slides. Why antegrade cerebral perfusion is used at all, and then we want to focus on the main topic on how to use it and what questions should be considered. Obviously, antegrade cerebral perfusion is used when you do surgery in the ascending or the distal ascending aorta or the aortic arch, where you have to provide a bloodless field for your surgeon. And I only want to mention here that antegrade cerebral perfusion has to be regarded as a part of neuroprotection that comes along with often with hypothermia and with your perfusion strategy. So it's not only about flow, it's not only about pressure, it's not only about a quick surgeon or deep temperature, but it's the whole package. And when you consider changing something or optimizing something, it's useful to have the whole in mind. When you would go only for hypothermia, you see you will have 30 minutes time to do your anastomosis. So you have to have really quick surgeons, or you have to introduce antegrade cerebral perfusion as well. These has also risks, especially from the direct cannulation that can cause iatrogenic trauma to the vessel cannulated, or whenever you direct blood flow directly to the brain, anything else that shouldn't be in there, especially air, can go there as well. And if you don't really know how much flow will be good and just think the more the better, you can harm the brain as well by inducing hyperperfusion with brain edema and more embolic load. But all in all, there were only very little percentage that said they did not use antegrade cerebral perfusion at all. And this is what the evidence suggests as well, that conjunction of antegrade cerebral perfusion and deep hyperthermia cardiac arrest is beneficial for neurological outcome, and it's generally feasible and safe if you know what you're doing. So this is the number I will give you as an answer for the talk. This is what came from the poll as well, more or less. As a general rule, we will use 8 to 10 mils per kilogram body weight per minute. Obviously, this is data coming mostly from animal studies, but in the experience, this gives quite good results all over the world. And we did a small study ourselves, which is not yet published, but where we came to the conclusion that 8 mils is a good target to aim for. And then you have to monitor what you're doing and whether you achieve your goal of matching the brain's supply to the brain's oxygen demand. The lower threshold, ischemic threshold, this was established in animal studies. As you can imagine, it's quite difficult to do this in a patient, or at least I wouldn't be the one presenting that to our EACTAIC committee. But they found that below a flow of 6 milliliters per kilogram body weight per minute, at least in pigs, ischemia occurred in the brain. On the other hand, you want to avoid hyperperfusion leading to an elevated ICP by edema and possibly an elevated embolic load. And this was also from an animal studies, also in pigs, where they compared a flow of 18 mils per kilogram body weight per minute to 8 milliliter per kilogram body weight per minute. And they found there was no benefit for oxygen supply and metabolic rate, but there was an elevation in ICP. And there was another study, I will mention this one because I personally find it very interesting, as it aimed for perfusion pressure and not for flow, which is obviously related, especially if you don't change resistance of the system. But when you look at the data, you see that to reach a CPP of 90, which is really high for comparing what we probably